Let's start with these questions. I gave you a set of 20 questions, but you have to remember the 20 questions that I actually gave, they genuinely, I mean it, they were generally the 20 most important questions of pediatrics to say the least. Most of the questions in FMG that will be asked to you. So there will be around 7 to 15 questions in FMG. If we look at past trends, in every exam, you have around 7 to 15 questions coming from pediatrics. Can be as low as 7 to 8 and can be as high as 15 to 16. Most of them actually come from two broad, if I divide pediatrics into three broad topics, general pediatrics, neonatology, and systemic pediatrics, most of them will actually come from what? They will come from general pediatrics and neonatology. Even in neonatology, most of the questions are actually from neonatal respiratory disorders. You'll have this broad understanding only if you solve past questions, past 5 to 7 year questions, and you'll actually be able to make a trend out of it. All right. And most of the questions which I gave you here, they are from that trend itself. They are either modifications of past year FMG questions or past year FMG actual previous year questions, or questions which are from the similar topics. All right. So these are the previous year topics are the important ones. 70 to 80% of the paper will be from those. So in the 70-80%, if you have a 70% strike rate, you'll easily pass. Right. With that little bit of background, let's start. So the first question I'd given was a newborn's baby's length measures 50 centimeter at birth. At 50 centimeter at birth, considering normal growth and development, what will be the approximate height at around 4 years? What will be the approximate height at around 4 years? So a lot of you are answering it. A lot of you are answering it in the chat box. A lot of you are answering B. So yes, you guys are right. The answer here is going to be what? Answer here is going to be B. But before I come to the actual answer, let me discuss about this a little bit. Now, discussing about normal growth, how does normal growth actually occur? When a baby is born, the birth length is, as given in the question, the birth length is what? It is 50 centimeter. It is what? It is 50 centimeter. In the first year of life, remember, in the first year of life, pehle saal mein, the bacha is going to gain, the baby is going to gain how much? Baby is going to gain 25 centimeter of length. Baby is going to gain how much? 25 centimeter of length. So that by the time the child is 1 year of age, the length of the baby is going to be what? 50 plus 25 is what? 75 centimeter, right? 75 centimeter. In the next 1 year, baby is going to gain half of what it gained in the first year. So in the first year, it gained how much? 25. So next year, it will gain half of it. So it will gain how much? It will gain only 12 to 13 centimeter, around 12 to 13 centimeter. Half of 25 is 12.5, right? So 12 to 13 centimeter. That's what we write. So at 2 years of age, the length of the baby is going to be what? 75 plus 12. So it's going to be around 87 to 88 centimeter. Okay. Then for the next 2 years, baby is going to gain half of what it gained in the second year. Baby is going to gain half of what it gained in the second year. So it gained 12 to 13 centimeter in the second year. Now it's going to gain 6 to 7 centimeter. It's going to gain how much? 6 to 7 centimeter per year. So at 3 years, 87 plus 6, how much? 87 plus 6, 6.5, how much? 93 to 94 centimeter. 93 to 94 centimeter. And another 6 to 7 centimeter. So at 4 years of age, this will become what? This will become 100 centimeter. This will become what? It will become 100 centimeter. So as you all have rightly mentioned, the correct answer is going to be option B, 100 centimeter. Is going to be 100 centimeter. At 4 years, the length of the baby is 100 centimeter. Now, there are multiple ways from this as someone rightly pointed out here, this particular table that I made for you guys, this question can be asked in another different manner. At what age? And this was the exact question which was asked in one INI-CT. At what age does birth length double? At what age does the birth length double? So birth length is 50 centimeter. Double 15 to 2 is 100 centimeter. 100 centimeter is occurring at 4 years. So at what age does the birth length double? The answer is 4 years. So this is the way. This is one simple question, but they can ask it in multiple different manners. You have to understand. They can tell you when does the birth length double? It is going to be 4 years. They can simply ask you at what age is the height 100 centimeter. Again, the answer is going to be 4 years. Or they can ask you at 4 years what is going to be the height, the one which is given here, the question which is given here, like that. So this simple table 50, 75, 87, 90, 300. If you remember this, you'll be able to solve you will be able to solve most of the questions. They have another question. They have asked another question. At what age is length half of adult height? At what age is length half of adult height? Okay. So the correct answer here is going to be, so what is the adult height? First of all, what is adult height? So adult height is approximately 170 to 175 centimeter. Right? This is approximate adult height, 5'7", 5'8", something like that. So half of this is what? It is 85 centimeter. 170 divided by 2 is 85 centimeter. 170 divided by 2 is 85 centimeter. So when is the child 85 centimeter? Can you see? At around this age, at around 2 years. So answer to this question is going to be at around 2 years. At around what? At around 2 years. When is the height of a child half that of adult height? The answer is around 2 years. So with this simple table, you can understand how they can flip around and ask multiple questions. All right. They can simply ask you what is the height gain in the first year also. That's a very simple question that they can ask you. All right. And this is how they can ask you multiple questions from this simple table: 50, 75, 87, 200. All right. After 4 years, another important thing I want to tell you, after 4 years, the height increase plateaus. It does what? It plateaus till puberty. This is something which we all have experienced, right? That till 4 years will become 100 centimeter. After that, height is going to gain at a plateau only. Slowly, 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 it will keep on increasing till puberty. In puberty, you will have your growth spurt, and everyone amongst knows that during puberty, when we have your growth spurt, suddenly the height increases. Suddenly, during puberty, the height increases. All right. So this is something which you should remember. This brings me to the second question. Because this is related to the fact that I just told you now. Gonadal growth corresponds with skeletal system, brain, dental growth, lymphoid growth. So I just told you, right, that skeletal system is what? Skeletal system is making up your height, right? So height initially grows very fast till 4 years, then it plateaus, and then when puberty hits, it again grows. This is how it normally happens. This is how normally your height is going to grow. Height is what? Nothing but your skeletal system. That initially in the first 4 years, it will go very fast. Then it will plateau and then it will again go very fast when puberty. And when will gonadal growth occur? It will also occur during puberty. Gonadal growth also occurs during puberty. So gonadal growth corresponds with what? It will correspond with the skeletal system. The correct answer here is going to be option A, skeletal system. And this brings me to the very important growth curves. These were asked in this year NEET PG. They were asked in this year's NEET PG. And that's why it's very important to know about them, because they can again ask this in this January FMG. All right. So first growth tissue is what? Somatic tissue. Somatic tissue is nothing but your skeletal tissue. It is nothing but your skeletal tissue. So like I said, in the first 4 years, growing very rapidly, 25, then 12, then 6 to 7 centimeter. So first 4 years, it grows very rapidly. Then it plateaus. Till what? Till puberty. And in puberty, again, there's going to be an uptick. And this uptick is what? This is nothing but your growth spurt. So this is somatic tissue and skeletal tissue. As far as lymphoid tissue is concerned, lymphoid tissue has this kind of growth pattern. Maximum growth occurs between 4 to 8 years. Maximum growth is going to occur between 4 to 8 years. So the maximum growth is from 4 to 8 years. As far as brain is concerned, very important. Maximum brain development occurs during the first 2 years of life. And after that, it's a plateau. So the growth curve of brain is going to look something like this. That in the first 2 years itself, 90% of growth has already occurred. In the first 2 years itself, 90% of the growth has occurred, and then it is going to plateau. And if I make the last one, which I asked right now, that is your gonads. Gonads are going to stay silent till puberty. Gonads are going to stay silent till puberty. And when finally puberty hits, then gonads are going to grow. So this is the reason why. If you look at this part of the somatic tissue curve, and if you look at this gonads, both these things are occurring simultaneously. As the gonadal tissue growth is occurring, simultaneously the skeletal tissue growth, the growth spurt is also occurring. That's why the correct answer to this question is gonadal growth corresponds with what? Answer A, skeletal system. It corresponds with what? It corresponds with skeletal system. All right. Moving on to the next question. A child presents with perioral rash and pigmentation of palmar area. What is the cause? Which deficiency is the cause? So everyone is absolutely correct. The answer here is zinc. I want you guys to remember two things, two frequently tested facts. Vitamin A and zinc both are required. Both are required for epithelial function. They are required for what? Both are required for epithelial function. They're required to maintain the integrity of the epithelium. So anytime there is vitamin A deficiency or anytime there is zinc deficiency also, you will have problem with the epithelium. So in zinc deficiency, in zinc A deficiency, you typically tend to have what is called as acrodermatitis enteropathica. Zinc deficiency is typically seen in the name of that disease, acrodermatitis enteropathica. I won't go into too much details, but the name itself is telling you acrodermatitis. There is going to be dermatitis. Why dermatitis? Like I said, zinc is required for what? It is required for epithelial function. So if the epithelial function is not there, what is going to happen? Dermatitis is going to happen. Typically, this dermatitis is occurs where? Occurs in acral regions. What are these acral regions? Perioral region. Which region? Perioral region. Perianal region, around the anus. These are the areas where the dermatitis will be very, very severe. That's why acrodermatitis. And enteropathica, if the epithelial lining, if there is if the epithelial lining, if the epithelial lining is not there of the gut, what will happen? You will have diarrhea. That's why enteropathica. This is nothing but diarrhea. This is nothing but diarrhea. All right. Someone commented that it was looking like a case of hand, foot, and mouth disease. Like, for example, fair enough. You are saying that there is palmar pigmentation, perioral rash. Sure, something similar can happen in hand, foot, and mouth disease also. But is there in the option here? No. Why do we want to think about this? Why do you want to think about diaper syndrome? Why do you want to think about hand, foot, and mouth oral disease? Okay, don't overthink. Think the best. This is something which I want to tell you guys right now, as far as attempting MCQs is concerned. What's the best part about attempting MCQs? And most people don't realize this. Answer is in front of you. It's not a subjective exam, it's an objective exam. They're giving the answer in front of you. All right, they're not asking you to write down the differentials of having pigmentation on palmar area or perioral rash. Do you need to know that? No, fair enough. If you want, remember that, if you have your concepts, great. But for this particular question, they're giving you four different ions. They're giving you four different minerals. So your thinking should immediately be restricted to that only. Why do you want to think about hand, foot, and mouth disease in this question? If the options themselves are not talking about hand, foot, and mouth disease, the options are not talking about diaper or whatever differential that you guys were thinking about it, right? Why do you want to think in that way? So you have to understand, this is a very important thing I want to tell you. The answer here is going to be what? It's going to be zinc. It's very simple. A lot of you must have gotten it correct. But the broader principle that I want to tell you in the exam, think straight. All right, don't deviate here and there. The examiner is simply asking you, perioral rash. I've given you perioral rash. Tell me the deficiency of which metal or which mineral it is. Plain and simple. And you should immediately think zinc. Is he asking about virus? No. Is he asking about diapers? No. So why are we thinking about that? We should think straight, right? Sure, in the real world, no doubt about that. When I am practicing as a pediatrician, I will keep all the differentials in my mind, no doubt about that. And that's a very good thing. That shows, two-step thinking for people who are thinking about this. But on the exam day, you have to be very straight. Don't think here and there. Okay. And I'll talk about what not to do. Okay. A lot of people talk about what to do. I'll also talk about what not to do. And this is one of the things I really want to emphasize. Don't overthink. Think straight. Right? Moving to the next question. Which of the following is not associated with this presentation? Now, I really want you guys to understand. I really want you guys to understand about this particular question. See, This here is what is called as Castle's necklace. This is what is called as Castle's necklace. So basically, I've given you a picture of what? I've given you a picture of pellagra. Pellagra occurs because of niacin deficiency. Pellagra occurs because of niacin deficiency. This is something which you must be knowing. And in pellagra, there are 3 Ds. What are the 3 Ds? Diarrhea, dementia, and dermatitis. And sometimes they say there's a 4th D, which is death. All right. This is vitamin B3 niacin deficiency. This is vitamin B3 or niacin deficiency. Now, one thing I really want you guys to emphasize. Let's say, for example, you get a question, this similar question in the exam, and you're not able to identify this image. Let's assume that. Let's assume you're not able to identify this image, and it can happen. We all know how sometimes faulty the tech is as far as Indian exams are concerned. You might not be able to see the image. The image might be blurred. Okay, and you might not be able to decipher it properly. What I really want you guys to understand, see, even if let's say you could not decipher the image, look at the options. Again, I'm telling you, the best part about this exam is answer is in front of you. In MCQs, the answer is in front of you. So diarrhea, dementia, deafness, dermatitis. Even if you did not understand the image, you could have made out diarrhea, dementia, and dermatitis. These 3 things, they are what? They are in pellagra. And question is asking which of the following is not associated. So even if you did not understand the image, with a little bit of thinking, with a little bit of logical thinking, these 3 things are there in pellagra. But this thing is not there in pellagra. This thing is not there in pellagra. So this image probably is of pellagra only, and they're asking which is not there in pellagra. So answer should be what? Answer should be C. Answer should be C. The answer here is C. Deafness is not there in pellagra. So even if you did not understand the, let's say I know that most of you would have understood the image. You might have made out the Castle's necklace. All right, the dermatitis which has occurred over the sun exposed area. Sure. But let's say the image is not great. Even then, from simply by looking at the options, you can know that these 3 things are there in pellagra and they're asking not associated with it. So you can make an educated guess that the answer is going to be option C, deafness. All right. With that, let's move on to the next question. The feature shown in the image below is characteristic manifestation of deficiency of which of the following micronutrient? All right, so first let's understand what they're telling. So they're giving you vascularization. They're giving you neovascularization. They're giving you what? This is nothing but neovascularization. This is nothing but neovascularization of cornea. And this neovascularization of cornea occurs in riboflavin deficiency. So correct answer here is going to be option B. Riboflavin. Correct answer is going to be option B, riboflavin. This is something which you have to remember. The reason I gave this question is because a lot of the times what happens, the reason I gave this question is, although the option is not there. Let's say one of the options was vitamin A. Let's say one of the options is vitamin A. Okay. Now, what happens is anytime you see something related to eyes, the mind automatically goes towards, oh, the answer should be what? Answer should be vitamin A. So the reason I gave this question was that take a pause, see the question carefully. Here the question was giving you what? Here the question was specifically giving you neovascularization of cornea. In case of vitamin A deficiency, there is corneal xerosis, right? There is corneal xerosis. The cornea becomes dry. Here there is neovascularization of cornea. So don't be in a hurry to mark an option. Okay, think logically. If they're giving you neovascularization of cornea, it is riboflavin deficiency. If they gave you corneal xerosis, it would have been vitamin A deficiency, right? So correct answer is going to be option 2, riboflavin. All right. Correct answer is going to be riboflavin. Now, moving on to the next question. This is a very important question. I'm going to explain a very important concept to you guys. A mother complains that her child is reluctant when it comes to taking feeds. A 15-month-old boy has a length for age. The length for age is what? Less than minus 2 standard deviation. It is less than minus 2 standard deviation. What is the likely diagnosis? What is the likely diagnosis? Okay. Now, I want you guys to understand the difference between chronic and acute malnutrition. All right. Now, please tell me in the comment section. Let's say all of us. For example, I'm suffering from a otitis media right now, and I don't take food for next 10 days. My appetite is reduced for the next 10 days. My feeding is reduced for the next 10 days, 15 days. Acutely, it is reduced. What will happen? Will my height decrease or will my weight decrease? Tell me. Exactly. Right? We gain weight very rapidly and we lose weight also very rapidly. If you don't take anything, if you're have something which happens very acutely, you don't take food for 5 days, 7 days, 10 days, they don't have proper appetite for that, you'll immediately lose weight. And this is something which we all have experienced. While contrast this with length, length grows very slowly, yaar. Dheere, dheere, dheere. 50 centimeter, for 75, doubling weight takes 4 years. Weight doubling takes only 5 months. It takes very slow time. Length takes aram se, itminan se. So acute malnutrition will always be judged by a parameter which is weight based, while chronic malnutrition will be judged by a parameter which is length based. On a long period of time, it is your length which gets affected. If you have not think about it logically, if you have not taken food properly for 10 years, 15 years, someone who is from a very super socioeconomic strata, what's going to happen? They're going to be very, very short in height, right? Even after that, if they take a lot of food, they will increase their weight. They won't be able to increase their height. While if you suddenly stop taking anything, you will suddenly have a weight loss. So chronically, it is always going to be what? It is going to be length. Chronic and something which takes time is going to be length. Something which is very fast, it's going to be weight. So acute malnutrition is best judged by, acute malnutrition is best assessed by what? It is best assessed by weight for length. It is best assessed by weight for length. But chronic malnutrition is best assessed by length for age. It is best assessed by length for age. All right. Now, if this weight for length is less than -2 standard deviation, it is called as moderate acute malnutrition. If it is less than -3 standard deviation, further low, then it's called severe acute malnutrition. Severe acute malnutrition. If the length for age or the height for age is less than -2 standard deviation, it's called moderate chronic malnutrition. It is called moderate chronic malnutrition. If it is less than -3, it's called severe chronic malnutrition. Same thing. Severe chronic malnutrition. Right. Another name for acute malnutrition is wasting. Another name from chronic malnutrition is stunting. Another name from chronic malnutrition is stunting. So this moderate chronic malnutrition can also be called moderate stunting. Severe chronic malnutrition can also be called severe stunting. Similarly, this moderate acute malnutrition can be called moderate wasting, and this severe acute malnutrition can be called severe wasting. So acute malnutrition, also another term for acute malnutrition is wasting. Another term for chronic malnutrition is stunting. So here what they had given length for age less than -2 standard deviation. Length means chronic. Okay. So acute malnutrition is out. Wasting is what? Wasting is again acute malnutrition. It is again acute malnutrition. So this is also out. Underweight again, no relation to weight of length for age or chronic malnutrition. So answer is going to be option 4, moderate stunting. Stunting is chronic malnutrition and it's less than -2, not less than -3. If it would have been less than -3, it would have been severe chronic malnutrition or severe stunting. So the correct answer is going to be option 4, moderate stunting. It's going to be option 4, that is moderate stunting. All right, moving on to the next question. This is something which we discussed last time that we had this session. Last time when we had this session. All right, tell me the answer. A 5-month-old baby referred to tertiary hospital from rural camp. Mother gave history of repeated episode of cough and fever with poor feeding habits. All are true given in the image except. All right, so what is this image? Tell me what is this image? All right, tell me what is this image? This is what? Exactly. So we can easily see that this is basically a child of marasmus. As everyone is pointing out, this is a child of marasmus. All right, you can see the characteristic muscle wasting. We discussed last time, right? That marasmus is what? Marasmus is M for muscle wasting. There is somatic protein loss. While in case of Kwashiorkor, there is Visceral protein loss. There is what? Visceral protein loss. In Kwashiorkor, there is visceral protein loss. All right. So in Kwashiorkor, when there is visceral protein loss, when there is loss of neurotransmitter, child becomes very lethargic or apathetic. While in case of marasmus, those neurotransmitters are still there and child is not getting anything. So child is very irritable, not apathetic. So they're asking which of the following things will not be seen except. They are asking except. So apathy, option 3, apathy won't be seen. Why? Because in marasmus, child is irritable, not apathetic, not lethargic. Child is irritable, right? Exactly. As Dr. Anand pointed out, marasmus mara hua jaisa. Okay, so in Kwashiorkor, a little bit, let's just revising from last time. In Kwashiorkor, child is what? Lethargic. Child is lethargic. In marasmus, child is irritable. Child is what? Irritable. Appetite wise, since the child is lethargic in Kwashiorkor, there is no visceral protein, no neurotransmitters. The appetite is also lost. No appetite. Poor appetite. While in marasmus, appetite is present. Appetite is present. Appearance wise, Kwashiorkor, because they have a lot of edema. Why? Because the albumin is lost. Albumin is lost or reduced. They lose what? They lose visceral protein. They lose visceral protein. So when the albumin is lost or reduced, they will have a lot of edema. So appearance wise, they will have a lot of edema, which is called moon faces. Which is called moon faces. Well, in marasmus, albumin is normal. Albumin is normal. And their appearance is what? Their appearance is simian faces. Simian faces. Just like this. Can you see? Because the loss of buccal part like that, that is called simian faces. That's called simian faces. Now moving to the next question. This is another very important topic. So something which I want you guys to understand, that please revise breast milk. Very important topic from your FMG point of view. Breast milk is something, I'll show this slide. Just you can see the slide. Breast milk is something which will definitely be asked. Breast milk is something which will definitely be asked. All right. Now, moving on. Question is, what is found more in human milk as compared to cow's milk? Breast milk versus cow's milk is a favorite topic of examiner. Breast milk, human breast milk versus cow's milk, very common. Yes, I will provide the PDF. Last time also I provided a PDF. You can check in the group. You can ask them where the PDF is. This time also I'll provide the PDF. Don't worry about that. What is found more in human milk as compared to cow's milk? Tell me. What is the answer? So yes, you are right. What is found more in human milk as compared to cow milk? The correct answer is going to be more. It's found more in human milk. So correct answer here is lactose. Correct answer here is what? Lactose. Correct answer here is lactose. Okay. Now let's understand the differences between human milk, human breast milk, and cow's milk. So in case of human breast milk, the lactose is, like I said, more. It is 7 gram per deciliter. While in cow's milk, it is only 4 grams per deciliter. It is only 4 grams per deciliter. Protein is less in human breast milk. It is more in cow's milk. But there's an important difference between the protein. In case of human breast milk, the ratio of whey to casein is 60:40. It is what? 60:40. While in case of cow's milk, it is 20:80. And this casein is more in cow's milk. C for casein, C for cow's milk. This casein, C for casein, C for cow's milk, C for casein being more in cow's milk, tends to form a coagulum. Tends to form what? It tends to form. It coagulates. And if it's coagulate, will it be absorbable? No, not absorbed. Not absorbed. So even though the human breast milk has less protein, even though the human breast milk has less protein, because it has more whey, the ratio of whey is more, it is more absorbable. While in case of cow's milk, because it has more casein, which tends to form a coagulum, it will not be absorbed. It will not be absorbed. All right. Now, as far as fats is concerned, these are similar. So human breast milk and cow's milk both have similar amount of fat. It is around 3 to 4 gram per deciliter. It is around similar. So human and breast milk and cows, fats is similar. The only difference is in human breast milk, you have increased amount of DHA. And this DHA helps in brain growth. This helps in brain growth. So human breast milk has more DHA, which helps in brain growth. That's why, again, human breast milk is better. And last is calcium phosphate. As far as calcium phosphate is concerned, 35 mg is to 15 mg. 130 is to 90 mg. If you look at the absolute value, cow's milk will have more. Human breast milk has calcium of only 35. While cow's milk has what? How much? It has 130. All right. It is 130. But what's more important to understand? That here the ratio of calcium to phosphate is around 2:1. And this 2:1 ratio and this ratio of 2:1 helps in better absorption of calcium. Helps in better absorption of calcium. And despite having a higher amount of calcium in cow's milk, this ratio results in less absorption of calcium. You need a 2:1 ratio of calcium to phosphate. Otherwise, the phosphate is going to chelate the calcium and not allow the calcium to be absorbed. That is the reason why in human breast milk, even though the calcium is lesser, it is absorbed better because the ratio is 2:1. While in case of cow's milk, there is what? There is less absorption. There is less absorption. There is what? Less absorption. All right. Now, moving on to the next question. Next question is very important. Something a very simple question, but something which has been asked multiple times. That's why I gave it. This is which every one of you should answer it correctly, and you are answering correctly. Is answer vitamin K. So, which of the following vitamin is breast milk deficient in? The answer is there's going to be two options. It's going to be vitamin D and vitamin K. These are the only two things human breast milk is deficient in. These are the only two things human breast milk is deficient in. Always remember this. The only two vitamins human breast milk is deficient in is vitamin D and vitamin K. For vitamin K, what do? We give injection vitamin K at birth. We give injection vitamin K intramuscularly at birth. And for vitamin D, what do? We give vitamin D drops for 1 year. We give vitamin D drops for 1 year. So that's how we compensate for the lack of this as far as human breast milk is concerned. Vitamin K, we give an injection. Vitamin D, we give drops. All right. Yes, this is the last slide. You can look at the last slide and take a picture of the last slide. Dosage is not that important. Nobody has asked the dosage to be very important, very honest. As far as vitamin K is concerned, just remember that vitamin K is given at birth. Okay. Now, moving to the next question. Moving to the next question. So this is now I'm going to discuss a little bit of, I'll try to make them a little bit easier for you guys to understand, especially the gross motor milestones. All right. A mother is bringing her toddler to a well child clinic, reports that her son babbles a few words, which make no sense. Okay. The child is also able to walk without support. This is the most important thing. He's able to do what? He's able to walk without support. What would be the child's approximate age? What will be the child approximate age? All right. So let's understand this. So how I remember these gross developmental milestones, how I remember gross motor milestones, how I remember the gross motor milestones. So always make the stick figure. What will I always do? I will always make this stick figure. Can you see the stick figure? All right. So I'll always make this stick figure. You cannot. Okay, I'll tell you something. Something very important related to milestones. Milestones is something which is very fragile, which is very volatile. And I'll be very honest with you guys. No pediatrician also remembers all the milestones on a given time point. Everyone tends to forget milestones. Okay, there is no way to remember. Unfortunately, it's one of the few things which is hardcore rote memorization. Okay, even for my exam, when I cracked my postgraduate entrance exam, I revised it one day before the exam. Not even one day, I revised it 1 hour before the exam. When I was going to the exam center, when my parents were taking me to the exam center, in the car, I revised the developmental milestones. So try to, the only way to remember is them is trying to revise them again and again and again and again. That's it. There is unfortunately, and you can even meet the HOD of pediatrics at AIIMS or any other hospital for that matter. Everyone will tell you milestones 8 point के बाद रट्टा ही है. You have to rote memorize it. And they are important, no doubt. One question is definitely going to come from milestones. So my simple advice to you is, we all talk about the last 7 to 10 day revision. This is why this last 7 to 10 day revision is important. You haven't revised milestones, you won't get that answer correct. Plain and simple. If you have revised milestones, you will 100% get the answer correct. You will 100% get the answer correct. So ensure that you keep milestones. It's 4 tables. At the end of the day, it's 4 tables, right? Gross motor, fine motor, social and language. It's 4 tables. Just revise it just before you're going to the exam, or like, the last thing that you read just before you're sleeping for the exam. But ensure you revise them on the last day. This is one thing I will tell you, everyone. A lot of you were telling me that how to remember milestones. यार रटना ही है. एक point के बाद it is rote memorization only. Just simply do one thing, that towards the end, revise them. Now, as far as gross motor milestones is concerned, I can make your life a little bit easier. Not too easier, but a little bit easier. Not too easier, but a little bit easier. Let's start. So if you make a stick figure here, if you make a stick figure like this, 3 months, 6 months, 9 months, 12 months. 3 months, 6 months, 9 months, 12 months. All right, 3 months, 6 months, 9 months, 12 months. So at 3 months, यहाँ पे क्या होगा? There's going to be what? There's going to be neck control. At 6 months, कहाँ पे control कहाँ पे आएगा? The control will be at the level of trunk. So trunk control means what? Child will be able to sit with support. Child is able to do what? Sit with support at 6 months. Child is able to do what? Sit with support at 6 months. At 9 months, the knees are strong. The knees are strong. So now that at 9 months, child will be able to stand with support. And at 12 months, now the feet are strong. Now the child will be able to walk with support. Now the child will be able to do what? Now feet are strong, so child will be able to walk with. Child will be able to walk with support. Child will be able to do what? Child will be able to walk with support. All right. Child will be able to walk with support. Now, if the child is able to walk with support, you will only be able to walk only if you are able to stand independently or stand without support, right? You can only walk अगर खड़े हो पाओगे. So at 12 months, if the child is able to walk with support, child will be able to do what at 12 months? Stand independently. So at 12 months, walk with support and stand. If you're able to stand independently, only then you will be able to walk. Similarly, if you will be able to stand only when you're able to sit without support. So at 9 months, when the child is able to stand with support, a little prior to that, at 8 months, child is able to sit without support. Child is able to sit without support. Child is able to sit without support at 8 months. All right. So this is how you can remember. 3 months, neck control. 6 months, sit with support. 9 months, stand with support. 12 months, walk with support. At 12 months, if you're able to walk with support, you will be able to stand independently. At 9 months, if you're able to stand with support, a little prior to that, you will be able to sit independently. That is sit without support. Simple. 3, 6, 9, 12. 3, 6, 9, 12. 3 पे neck control, 6 पे trunk control. मतलब sit with support. 9 months पे knee control, stand with support. 12 months पे feet control, walk with support. If at 12 months you are walking with support, 15 months, what you are going to do? You are going to walk independently. Walk independently. You're going to do what? You're going to do walk independently. Right? Now remember from ये जवानी है दीवानी, बनी क्या कहता था ये जवानी है दीवानी में? मैं ऑलराइट, मैं चलना चाहता हूं, मैं दौड़ना चाहता हूं, मैं उड़ना चाहता हूं. I want to walk, I want to run, I want to, you know, fly. So that's what child will also do. First, the child will run to walk. At 15 months, child is walking. At 18 months, child will run. And at 2 years, child will fly. Obviously, child won't be able to fly, but child will go up and down stairs. Flying is what? Up and down stairs. Up. Just 1 second, sorry. Up and downstairs. All right. So this is how you can remember the gross motor milestones. At 12 months, feet are 12 months what? Feet control. So walk with support. 15 months walk without support. पहले मैं चलना चाहता हूँ, मैं दौड़ना चाहता हूँ, मैं उड़ना चाहता हूँ. I want to walk, I want to run, I want to fly. 15 months walk, 18 months run, 2 years fly. Right? Then after this, now when he's going up and down, say at 2 years, he will be using 2 feet. He'll be using both the feet. 2 feet on the same step. 2 feet on same step. At 3 years, 3 for 3, 3 for tricycle. 3 for 3, 3 for tricycle. Now he'll be able to go upstairs 1 feet at a time, downstairs still 2 feet. Upstairs 1 feet, downstairs still 2 feet. At 4 years, 4 has what? 4 in it. Hops also has 4 letters in it. So at 4 years, child will be able to hop. And he'll be able to go both upstairs and downstairs 1 feet. Up and down, both now at 1 feet. Both now at 1 feet. At 5 years, 5 has what? 5 has what? 5 has 5 in it. Skips also has 5 letters in it. Skips also has 5 letters in it. So child will be able to do what? Skipping at 5 years of age. All right. Skipping at what? 5 years of age. So this is how you guys can remember at least the gross motor milestones. I thought I would make your gross motor milestones at least easy. A lot of it is memorization only, but at least this is how you can understand the gross motor milestones. 3 months neck control, 6 months trunk control, sit with support. 9 months knee control, stand with support. So if 9 months you're standing with support, you will be able to sit without support. At 12 months walk with support, so you'll be able to stand independently. 15 months मैं चलना चाहता हूँ, मैं दौड़ना चाहता हूँ, उड़ना चाहता हूँ. 15 months चलना, 18 months दौड़ना. 15 months you're able to walk, 18 months you're able to run, and 2 years you're able to fly. That is up and down stairs. 3 years, 3 for 3, 3 for tricycle. 4 for hops has 4 letters, 5 for 5 skips has 5 letters in it. So this is how you can remember the gross motor milestones at least. This is how you can remember the best gross motor milestones at least. So if I come back to the question was very clearly saying child is able to walk without support. Walk without support is what? Walk without support is 15 months. Walk without support is what? 15 months. So the answer is going to be option D, that is 15 months. Another thing that the question had said was, child babbles a few words which make no sense. This is nothing but jargon speech. This is nothing but jargon speech. And jargon speech is also seen at 15 months only. Jargon speech is also seen at 15 months. Okay. So, but again, if I go into too much into milestones, it's going to take a lot of time. So I'm going to restrict myself to gross motor milestones. But hopefully you have understood the gross motor milestones. Okay, moving on to the next question. The following karyotype is suggestive of which disorder? Tell me the answer. Following karyotype is suggestive of which disorder? What is going to be the answer here? All right, you guys are absolutely right. So we can clearly see here at chromosome that chromosome 13 instead of 2. There are 3. So there is trisomy of chromosome 13, and trisomy of chromosome 13 is nothing but Patau syndrome. It is nothing but option 1, that is Patau syndrome. Option A or Patau. All right. Now, most of the questions of Patau syndrome are going to be from the differences between Edward and Patau. There are going to be differences between Edward and Patau. You must have been given a table like this in most of your notes or from wherever you are doing. The very simple way, this is something which I really want you guys to understand. The very simple way you can understand the differences between Edward and Patau is, if you remember, Patau has what? P in it. Wherever you hear the sound of P, wherever you hear the sound of P or P in it, that thing is going to be present in Patau. If you don't hear the sound of P, that is not going to be there in Patau. That is not going to be there in Patau. If you hear the sound of P matlab Patau. If you don't hear the sound of P, matlab Edward. Let's understand. So E for Edward, E for 18. E for Edward, E for 18. So it is trisomy 18. P for Patau, P for puberty. When does puberty start? It starts at around 13. So trisomy 13. So trisomy 13. Edward is more common. Patau is a little less common. Now coming to the next question. Next very important thing. Rocker bottom feet. RBF, rocker bottom. Is there any P sound in it? Is there any P in it? In rocker bottom feet, is there any P in it? So if there is no P in it, rocker bottom feet will not be seen in Patau. It will be seen in Edward. It will be seen where? It will be seen in Edward. Next one. Cleft palate. Palate. P. Cleft palate. There's a P sound, right? So it will be seen in Patau. It will not be seen in Edward. Then comes holoprosencephaly. P. Holoprosencephaly. Cutis aplasia. P. Holoprosencephaly. Cutis aplasia. Both have P in it. Again Patau, not Edward. Horseshoe kidney. Again horseshoe kidney. No P in it. Horseshoe kidney. There is no P in it. Horseshoe kidney will be seen where? It will be seen in Edward. No P means Edward. Okay, and it will not be seen in Patau. Patau has what? Patau has polycystic kidney. P for Patau, P for polycystic. Then comes fingers. P for Patau, P for polydactyly. P for Patau, P for polydactyly. Edward has overlapping fingers. Edward has what? Overlapping fingers. So this is a very simple way you can remember difference between Edward and Patau. P से Patau, P से जहां P सुनाई दिया, P आहा Patau, है ना? Right? So this is how you can differentiate between Edward and Patau. This is how you can differentiate between Edward and Patau. All right. This is something which has been asked to me in the exam I gave, and this is something which has been asked multiple times. A very simple question. RBF is not seen in Patau. RBF, the name, no P in it. RBF is usually not seen in Patau. 90% cases don't have RBF in Patau. All right. What is the order of suctioning in neonatal resuscitation? So it's very simple to understand. A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P. M before N. Mouth first, then nose. M before N. Answer here is going to be option A. Mouth, nose. First you'll suction mouth, then you'll suction nose. Okay? M before N. M before N. So as far as neonatal resuscitation is concerned, the suctioning always mouth first, then nose. Why? Why do we do that actually? Let me, as Munaza has already pointed out, that is very, very true. You don't need to suction esophagus. Someone is asking why not 3? Why not 3? There is no need for esophageal suction. No need for tracheal or esophageal suction. You don't do tracheal or esophageal suction. Think about it. Child is born and you are going to put the entire suction catheter into the esophagus and suction. No, not required. Just here and here is more than enough. No need for esophageal, no need for tracheal suctioning also. There's no need for tracheal or esophageal suctioning also. That's why 3 and 4 are ruled out. All right, M before N. And as someone rightly pointed out, if you suction nose first, not mouth, if you suction nose first, what will happen? If there are some secretions in mouth, the child will aspirate those secretions. Think about this with, and I'm coughing right now, right? So I have a lot, let's say someone has a lot of secretion in mouth, some has a lot of secretion in nose. If you suction nose first, what will happen? Child can cough or child can get stimulated, and that stimulation will result in aspiration of the mouth secretion. That's why you always make sure the mouth is dry first and then suction nose. And then suction nose. Yes, I'll have green tea. Thank you for the advice. Right? So here the answer is going to be option A, mouth nose. Mouth nose. Moving to the next question, which of the following is true about transient tachypnea of the newborn? Which of the following is true about transient tachypnea of the newborn? The following is true about transient tachypnea of newborn. So the correct answer here, let's look at the options. Okay, interlobar fissure effusion, common in preterm infants. What is common in preterm infants? We all know respiratory distress syndrome is common in preterm infant. Air bronchogram on chest X-ray. This is also seen in respiratory distress syndrome. This is also seen in respiratory distress syndrome. Correct answer here is option 1. Correct answer is option 1, interlobar fissure effusion. Now we have to understand what this TTNB is. Why does it occur? So normally what happens and where will it be seen? Where will it commonly be seen? When you understand that concept, you will never forget the answer is A, interlobar fissure effusion. Normally when a child is being born, is going to get born through the vaginal canal, right? So vaginal canal is this small and this is how huge the baby is, right? This is normally, and the baby is going to get compressed through the vaginal canal and then come out through the vaginal canal. A normal delivery is a violent process. I always say this in the classes. A normal delivery is a rather a violent process. Now, there is some advantage to this process. When this baby comes through the vaginal canal, what happens? The sympathetic drive that is there will be a lot of sympathetic drive that causes absorption of the lung fluid. Inside the uterus, the lungs are collapsed and they're filled with fluid. And now when the baby has to come out, that fluid has to be reabsorbed, right? Now, when the baby comes out through that vaginal canal, simply the process itself causes a lot of resorption of the lung fluid, all right? Because of the sympathetic drive. Now, let's assume the child is not born via normal vaginal delivery. The child is born via LSCS. Will the child receive any form of stimulation, the sympathetic stimulation? The answer is no. And if the child doesn't receive any of the form of sympathetic stimulation, what will happen? The child will, Mawal, you can ask the question. You can ask the question towards the end of the session. We'll have a proper Q&A. We can have the question towards the end. Let me teach you guys right now, and then we'll ask the question towards the end. All right. I hope that answers you. Thank you, Mawal. Now, so cortisol and, someone is saying cortisol, I would say inside of cortisol, it's simple adrenaline, noradrenaline, they also will not be released in LSCS. All right. And when they are not released, what will happen? You will have a lot of retention of lung fluids. And this lung fluid retention, so where will this TTN be seen? TTN typically is seen in LSCS, typically is seen in infant of diabetic mothers. All right. And they will have a lot of retention of lung fluid. And when this lung fluid is retained, it will cause this interlobar fissure effusion. Between the lobes of the lung, you will see a line, you will see fluids in that. So this is what we will see as far as TTNB is concerned. All right. But why is it called transient tachypnea? Because after a point of time, this fluid is going to get reabsorbed. And this reabsorption will occur in 72 hours. That is 3 days. Body will reabsorb, lungs will reabsorb that fluid. Body has to survive, right? So this respiratory distress resolves in 2 weeks is incorrect. It resolves in 3 days. Okay. So this is how we differentiate between TTNB and RDS. So TTNB, can you see here? If you look at this particular image very carefully, this white line that you see here, this white line that you see here, This is nothing but that fluid which has accumulated between two lobes. And this shows that this is what? This is TTNB. Where it will be seen? It will be seen in LSCS. It will be seen in infant of diabetic mother. And it will be seen in term babies. There is no reason why it will be seen in preterm. These are the places where it will be seen. Well, as far as RDS is concerned, in RDS, you will see what? The peripheries are collapsed and the middle bronchus, they still remain open. So here, everywhere it is what? It is white out. It is white out. But if you look closely in this image also, if you look very closely in this image also, can you make out a little bit of shadow here? Can you make out a little bit of that? These are the two bronchus. That these are the two bronchus that are coming. All right, in which air is still there. This is what is called as air bronchogram. This is what is called as air bronchogram. And these air bronchograms will be seen where? They'll be seen in RDS only. They'll be seen in RDS. All right, so if you see air bronch, RDS is seen where? It is seen when preterms. It's seen in preterms. Why? Because of lack of surfactant. They are preterm, they have not been able to synthesize a lot of surfactant. Lung maturity is not there. So there will be lack of surfactant. So RDS is seen in preterm, there's lack of surfactant, and then they will have these air bronchograms. They will have these air bronchograms. So these are two very important disorders. If they give you term baby, infant of diabetic mother, LSCS, think TTNB. If they give you a preterm baby, they give you this air bronchograms, think RDS. All right. Now, moving to the next question. Something which we discussed last time also. Tell me the answer. Something which we discussed. What is the maintenance fluid? What is the daily maintenance fluid is required for 30 kg? Sorry. Yes, absolutely right. The correct answer is option 2, 1700. So first 10 kg, 10 into 100 is equal to 1000. Next 10 kg, 10 into 50 is equal to 500. And the next 10 kg, 10 into 20 is equal to 200. Add it all up, it becomes what? It becomes 1700 ml. So the answer is going to be 1700 ml. I'm not going to discuss this too much because we discussed this in the last session. Next very important question. Which of the following pathogens is responsible for largest fraction of death due to gastroenteritis in children less than 5 years? What's the answer here? Here also the answer is rotavirus. Answer here is going to be rotavirus. Now, I want you guys to understand that even if you did not know the actual answer, like this is technically a fact-based question, even for fact-based question, you can make educative guesses. Out of all these 4 options that are given, which one has a vaccine? Only rotavirus has a vaccine. So you try to create vaccine for things which kill a lot, which are very common, right? That's why rotavirus vaccine was the single most important priority as far as viral gastroenteritis was concerned, right? It is the most common also. Rotavirus is the most common also. It's the most common cause of death also. And it has a vaccine also. All these 3 things are valid for rotavirus. It is the most common also. It's the most common cause of death also. And it's the most common, has a vaccine also. Vaccine causes interception. That's the one pointed out. Sneha pointed out. This vaccine causes interception. But even for a fact-based question, sometimes you can make calculative guesses. Since your exam is not a negative mark-based exam, you have to attempt most of the questions. Please go for such questions also. Like, if I don't know which virus would it be, but I know that most common overall it is rotavirus, there is a rotavirus vaccine, mark rotavirus. So correct answer is going to be what? It's going to be rotavirus. All right. Next question. What's going to be the answer here? What's going to be the answer here? All right. So most of you are telling it correctly. Answer is going to be option C. So let's discuss the IMNCI management. Let's see the IMNCI management once. So IMNCI says if a child comes to you with any form of respiratory distress, you'll classify the child as having no pneumonia, pneumonia, or severe pneumonia, or very severe disease. No pneumonia means only cough and cold. No pneumonia means what? Only cough and cold. Pneumonia is of two types. Pneumonia is of two types. One is fast breathing pneumonia. Another is chest indrawing. Fast breathing pneumonia means you're saying the child is having pneumonia simply on the basis of respiratory rate. He's breathing very fast. You're saying the child is having pneumonia simply on the basis of respiratory rate. So this respiratory rate has to have a cutoff. So what are the cutoffs? Less than 2 months, it's 60. 2 to 12 months, it's 50. And more than 12 months, it's 40. So any child more than, let's say, 1 year, respiratory rate more than 40 means fast breathing pneumonia. Automatically means fast breathing pneumonia. If a child is having chest indrawing, again, irrespective of the respiratory rate, child will be having what? Child will be having as pneumonia. Now, severe pneumonia. When do you call that it is severe pneumonia? When do you call it as severe pneumonia? You'll call it as severe pneumonia if there is stridor in a calm child, or signs of very severe disease. What are these signs of very severe disease? Convulsions, seizures, high grade fever, poor feeding and lethargy. All right, seizures, poor feeding, lethargy, high grade fever. If these things are seen, then you'll say it as severe pneumonia. If these things are not seen, then either it is no pneumonia or pneumonia. In no pneumonia, you don't need to do anything, nothing. Soothing measures. Soothing measures. That's it. In pneumonia, you will give what? You will give oral amox. You will give oral antibiotic. You will give oral amox for 5 days. And you'll ask the parent to follow up after 2 days. Follow up after 2 days. In severe pneumonia cannot be managed in a primary health center. You have to refer. So what will you do? You will give the first dose of IV antibiotic and then refer. First dose of IV antibiotic, which can either be ampicillin or gentamicin, and then refer. First IV antibiotic and refer. Let's look at this question. First, they have given you an age. It is 1.5 years. That is more than 1 year. Okay. Was brought to hospital with history of breathlessness, fever, cough, and cold. Have they specified fever as high-grade fever? No. Simple fever. Respiratory rate was 46 per minute. So it's more than 40. And there were no chest retractions. So they have not given you, have they given you any of this? Have they given you stridor in the calm child? No. Have they given you seizures? No. Have they given you poor feeding? No. Have they given you high grade fever? They have given fever. So can be low grade. They have not specified as high grade fever. So this is nothing but pneumonia. This is simple pneumonia. Respiratory rate more than 40, fever, no signs of very severe disease. What is the most appropriate management? What is the management? Oral amox, oral antibiotic, oral antibiotic. So correct answer is going to be option C. Correct answer is going to be option C. Moving to the next question. Tell me the answer to this question. What is the answer? So something which you all know. This is something which you all know. This is chloride. So CFTR is the gene which is defective where in cystic fibrosis. And the CFTR is a chloride conductance channel. It's a chloride conductance channel. This is a very simple, straightforward question. Remember, it is an autosomal recessive disease, and the CFTR gene is present where? It's present on chromosome 7. And most common mutation is delta F508. Most common mutation is delta F508. So I won't teach you cystic fibrosis today. That will probably be, we'll teach you at some other point of time. But these are some simple facts related to cystic fibrosis, which you should remember. Okay, which you should remember. This is important. This is very important. This is something which I want to teach you. After this is probably the last question I'll discuss. Rest of the questions are actually they're not that tough. They're relatively easy, so I'm not going to discuss. Tell me the answer to this question. Because this has been asked multiple times again and again. So everyone is correct. This is what? This is total anomalous pulmonary venous connection. Okay. So they are saying there is a history of cyanosis, and they are telling chest X-ray shows what? Snowman appearance. So these are the 4 chest X-rays that you should remember. If they give you a snowman appearance or a figure of 8 appearance, then the answer is TAP PVC, total anomalous pulmonary venous connection. If they give you egg on string appearance, cyanosis plus chest X-ray showing egg on string appearance, then this is going to be what? TGA, transposition of great arteries. If they give you a boot-shaped heart, then the answer is going to be what? Then the answer is going to be tetralogy of Fallot, TOF. All right, the answer is going to be TOF. And if they give you this box-shaped heart, then the answer is going to be Epstein. It's going to be Epstein anomaly. It's going to be what? It's going to be Epstein anomaly. All right. Remember these 4 chest X-rays like your life depends on it. One of these chest X-rays is definitely going to come. All right. Figure of 8, TAP PVC, egg on string, TGA, core and sabot or boot-shaped heart, TOF, Epstein anomaly, box-shaped heart. All right. All right. So how many questions are we left with? Just left with 2 questions. I'll just tell the answer to this question. So coming from another question, tell me the answer. Everyone is correct. This is Epstein anomaly. So lithium intake causes Epstein anomaly. Lithium intake is associated with Epstein anomaly. So some maternal conditions which are associated with some cardiac defects. These are some simple one-liners. I want to do this one simple table. If there is an infant of diabetic mother, then the most common defect is VSD. Most specific is TGA. Lithium is Epstein anomaly, like we already discussed. In congenital rubella syndrome, the child is going to have PDA, patent ductus arteriosus. And in case of SLE, if the mother transfers anti-Ro antibodies, the baby is going to have heart block. Baby is going to have a heart block. Baby is going to have a heart block. All right. All right. So this is the last question is another simple question. The very last question is very simple question. Neural tube defect marker. Which of the following is a marker for neural tube defect? This is the last slide. You can take a picture of this last slide. Which of the following is a marker for neural tube defect? So neural tube defect has 2 markers. One is a sensitive marker and one is a specific marker. Sensitive is alpha-fetoprotein. Specific is acetylcholinesterase. Very important to know this. Neural tube defects for markers, antenatal markers. Sensitive is alpha-fetoprotein. Specific is acetylcholinesterase. So here the answer is going to be what? Acetylcholinesterase. These 3 are markers for Down syndrome. They are markers for Down syndrome. Right? So this is what. So with this, we complete the session. Most of the topics I've discussed. Now I'll talk about what not to do. Yes, I will share. I think the last time also the PDF was shared. There was a delay of 1 day, but I had shared it. I'll again share it again once. Don't worry about it. Okay, don't worry about the PDF. You'll get a PDF. Okay. Now, most important thing that I want to talk to you is what not to do. Koala, I'm not going to talk about seizures. See, I have 1 hour to teach you guys. I'm trying to teach you the most important topics. I cannot teach you the entire pediatrics in 1 hour. Okay? If you feel seizures are important, then there must be someone else who must be thinking some other topic is important. And I'm so sorry. I would love to teach you about seizures. Unfortunately, today I cannot you. Okay? What I really want to teach every one of you, which is for every single one of you, is not to do in the next 1 month of preparation, especially giving for your FMGE exam. And few pointers I've told you in the entire process in this last 1 hour itself also. What not to do. Don't overthink. Remember, FMG is a remember FMG is a screening test. Okay. And in screening tests, they're not testing for intelligence, they're screening you guys, first of all. Okay. Simple. The goal is to get 150. And if you want to appear for AIMS or INICT later, the goal is what? The goal is 165. 165, 170. No one is asking you to get 300. Don't overthink. Most of the questions are going to be simple, straightforward. They might be a little bit of they might be a little bit of, two-step thinking, but the questions are more or less going to, if your concepts are decently clear, most of the questions are going to be relatively simple or maybe moderate. Don't overthink. It's a very common thing that after you have done a lot of things, after you have revised a lot, after you have done your entire syllabus, you it's a very common thing that tends to happen. Oh, this must have been there, so this must have been there, so probably the examiner is trying to ask this. So the answer should not be this, the answer should be this. Don't do that. This is something which a lot of you will be do. You know, so, like for example, when we were discussing about perioral rash, I was thinking about hand, foot, and mouth disease. Why? If the options in front of you four are of metals, they are of minerals. Why are you thinking about hand, foot, and mouth disease? Be straightforward. Don't overthink. Especially on the exam day, don't overthink. Next thing, a very important thing. Don't leave a subject. At least rote memorize past 3 years PYQs. So it's fully possible that you have done around, let's say, 14 subjects. Okay, you've done 14 subjects and you're like, 5 subjects में छोड़ देता हूँ. Don't do that. My simple advice to you is, you have these modules, you have past year modules in Maro. पिछले 3 साल के papers के सिर्फ उन questions को रट के चले जाओ. Just rote memorize them. Even if you don't understand them properly, that's also still fine. I'm telling you, from let's say you are done 15 subjects, 4 subjects are left. Let's assume this is a scenario, which is a very good scenario. From these 15 subjects, you will get 260 questions or 270 questions. And from the 4 subjects, you will get, let's say, 30 questions. Out of these 30 questions, I'm 100% sure 10 questions can be repeats or similar repeats, not too different. You'll get these 10 correct. And then in the remaining 20, mark everything as option A for everything as option D or everything as option C, whichever you feel like. You'll still get 5 correct. Simple probability, 25% of option correct. You'll still be able to get 15 out of 30. You'll still be able to get 15 out of 30. Right? So don't leave a subject. Very important. Don't leave a subject. Just do the past 3 years previous year questions. Just from the Maro modules, you must be having them. That's more than enough. But don't leave a subject. Okay. Focus on these 15 subjects that you have done. Revise them thoroughly. And for these 4 subjects, don't take too much tension now. Don't be like, I'm going to complete these subjects and then I'm going to go do revision. No, now the time is to revise. Revise these 15 subjects, and for these 4 subjects, just do the past 3-4 years of previous year questions. You'll still be able to get 30-40% questions correct. I'm 100% sure about that. All right. Another thing, very important mistake that a lot of people make. All right. Practice GT, but don't take GT in last 7 days. So I would actually advise you guys to take a GT in the next coming week, but don't take it in the last 1 week before or the last 10 days before the exam. Because last 10 days before the exam, if you take a GT, what will happen? If let's say the GT doesn't go well, it will, suddenly take your confidence down. That GT is not going to affect the actual score, right? Take a GT right now, maybe improve, understand how to sit in the exam for 3.5 hours, but don't take a GT in the last 7 days. There's something which I really want you guys to understand. Take a GT now. Today 17, take now, take by 27th, but don't take in January, or maybe definitely don't take it after 5th of January. Okay? Because that will just get your confidence down. But take 1 or 2 now in order to understand how the time pressure works. All right. Don't focus on low yield topics. Revise important. So this is not probably for the ones who are aiming to just pass at this point of time. A lot of people who probably would be getting regular scores in 180, 190, what tends to happen and what causes them to drop from 180 to 115 on the actual exam day, or maybe not even pass. And this is very important, I'm trying to tell you. That as you keep on building confidence, a lot of people, what tends to happen to a lot of them now, then they start to think about, ye bhi pad leta hu. This is nothing but FOMO. This is nothing but FOMO of This is nothing but FOMO of information. Fear of missing out. This is nothing but FOMO of information. Focus on the high yield topics. You guys already know what the high yield topics are. You know, in case of pediatrics, what is high yield? You know, it is Kwashiorkor, Marasmus. You know, it is SAM. You know, it is growth and development. The milestones. Everyone was talking about milestones. Everyone knows milestones are important. Focus on important topics. Don't go suddenly into obscure topics. Don't suddenly be like, what is the proper management of, I will go in depth about treatment of juvenile idiopathic arthritis. In past 5 years, maybe one question was asked about juvenile idiopathic arthritis. No point. I will discuss everything related to, congenital heart diseases. Most of the times questions are related to only TOF. You just need to do tetralogy of Fowlett. That is more than enough. If you're not even understanding other diseases, that's fine. Do the X-rays. X-rays are important, but understand TOF. Right? Don't focus on low yield topics. Revise the high yield topics again and again. Okay. And last thing I want to tell is, don't screw up last 7 days. And I just don't mean from the last revision point. A lot of people, what tends to happen, that they'll fall sick just like I am, for example. Do you think any person can be at their top A game if they're not healthy? So start to sleep on time from today. Ensure that you wake up at that, practice some MCQs during that time point when the FMGE exam is going to get conducted. That time period. Keep healthy during the last 7 days. Make sure your sleep cycle is fine. Please don't take drugs. A lot of people, use drugs to get through the sleep cycle. Don't do that. It will help. It will, cause problems with your memories only. So don't do that. So these are some important don'ts I think we should not do. Okay, as far as your exam is concerned. Most importantly, these are the two most important don'ts. Don't overthink. Simple, straightforward. ठीक रहेगा. And most importantly, don't focus on low yield topics. This is FOMO. Revise high yield topics again and again so that you don't get their questions incorrect. All right. Now we can come to this is done, I think. Just 1 second. Now we can have a Q&A if I'm just 1 second. Yeah. So some people have asked a Q&A. 1 second, just give me. Okay. Yeah. How you memorized all the PD and studying, doesn't you feel anxious and oppressed by toppers? So first of all, from an FMG point of view, is there any difference between a guy who got, let's say, a 250 versus a guy who got, let's say, 160 or 165? Your goal is to crack the exam, to get that, pass the exam. Focus on important high yield topics and revising them again and again. If someone is doing really well, right now, I'm not bothered about it. All right. Right now, I'm not bothered about it. Okay. Right now, I'm not bothered about it. So Why are you bothered about somehow someone else is doing? This is a very negative way of thinking. You should never oppress. What do you mean by oppressed by toppers? Are they for ensuring that you don't study? Why can't you be a topper? Why can't you put in more efforts? Why can't you do the more hard work? Why can't you be like, I'll also become a topper? Why are you focusing on them? Focus on yourself. Okay? खुद को बड़ा बनाओ. मैं करूंगा, मैं करके दिखाऊंगा. I can, I shall, I will. कैसे नहीं होगा? है ना? The thought process should be of a winning attitude, not a loser attitude. That I'm oppressed by toppers. I can, I shall, I will. करके दिखाऊंगा यार, कैसे नहीं होगा मेरा? That should be your attitude. टॉपर क्या कर रहा है भाई, क्या फर्क पड़ रहा है, भाड़ में जाए वो, राइट? Is doing PYTs and PYQ of last 5 years enough to pass the FMGE exam? Yes, the answer is yes, but you have to understand the previous year topics and you have to revise them in the last 1 week. Just doing them once is not sufficient. This is very important thing I want to. A lot of people, what will they will do? They will just do past 5 years MCQs, wrote to memorize them and think they will pass the exam. No. If you have understood those topics and if you have revised those topics in the last 7 days, then they are sufficient to pass the exam. Okay. सर एगॉन स्ट्रिंग एंड बूट शिफ्ट हार्ट में कंफ्यूजन रह रहा होता है. अच्छा ये दिखा देता हूँ, जस्ट शो यू वन मोमेंट. यार बूट शेप्ड हार्ट और एगॉन स्ट्रिंग में ना मैं एक बहुत इंपॉर्टेंट चीज मैं तुम्हें बताने वाला हूँ, मैं दिखा देता हूँ मैं तुम्हें. फोकस ऑन दिस एरिया. इन बूट शेप्ड हार्ट कैन यू सी दिस पार्ट इज वाइड. वो बूट के लिए वो जो लेग है ना वो मोटी होती है. एगॉन स्ट्रिंग में ना ये स्ट्रिंग होगा, बहुत पतला होगा ये वाला यार, बहुत ही पतला होगा. दिस इज हाउ यू कैन डिफरेंशिएट. दिस इज हाउ यू कैन डिफरेंशिएट. ओके. Sir, I'll appear for the next year's 2016 exam. My 13 subjects are left. I'll try to complete, but not able to revise. Can you give me a rough idea how to manage time? How should I manage? See, right now the goal should be that by next June-ish also, for that matter of fact. 13 subjects means that most of the syllabus have not been done. By June-ish also you can complete the syllabus and then do 2-3 revisions. That's more than enough, to be very honest. All right. Like your simple goal at this particular point of time should be, just give me a moment. Like by June, you should do the notes once. You should be able to do the notes once. Then June to September, one revision. In September to November, another revision. November, December, another revision. And then one final 10-day revision. So you'll have 2-3 revisions and you will be able to complete the syllabus. All right. And you should not focus on revision right now. Right now, the goal should be to make revisable content. By June, you should have your notes ready. Notes which can be revised. So now, right now, when you are reading something, make your own notes. Ideally, you should not, I'll be very honest about this. Every platform gives pre-made notes. You should make your own notes. From the videos, you should take out the most important bits yourself rather than relying on the pre-made notes, which will have everything written. You should take out the most important part and make your own notes. And get these notes ready by June. And then revise them 2-3 times. You'll be done. Physio and biochem are causing trouble. Yeah, I know that they are causing trouble. Maybe you can, how to improve a subject, the only goal way is to improve your MCQ practice. That's how you improve a subject. Is INICT question necessary? Just to pass 2 papers. So what the trend has been that the last 2-3 papers that they sometimes pick direct questions. So just do last, like, if you're going to give this November or last May, these 2 papers are more than enough. All right. Is it okay to do quick revision program from a different source? Ideally, no. If you have done one source properly, then if you do the quick revision program from that source itself, it will be better. Okay. If you have done PYTs but didn't solve PYQs, will that be okay? No. Big no. You have to solve the previous year questions, yeah. How do you know that you have done your previous year topics thoroughly if you have not solved the previous year questions? ये तो वही बात होगी, मैंने पूरी थ्योरी पढ़ ली, मैंने MCQ लगाई नहीं, कैसे निकल जाएगा एग्जाम? Both the things are important. PYQs help you understand the previous year topics, the topics which are important. Then you read those topics, you understand those topics, which helps you in solving the previous year question. But if you have not solved the previous year question, you have not done MCQ practice, then you will falter in the exam. So please solve the previous year questions. How to control anxiety in last 3 days? Breathing exercises. I used to do that. For me, the breathing exercises were the best ones. Nikita, you will be able to replicate the exam on the score on the exam day. Your scores are 160, 180, 200. So these are good scores. You should focus on revising, like I said, revising high yield topics. Maybe give a GT once or one more GT in the next 10 days. Don't get into FOMO of doing unimportant things. Revise the important topics again and again. That's what you should simply do. So how should I plan the last 10-day revision? So last 10-day revision is a proper separate topic. Maybe I'll make a YouTube. You can go to my YouTube channel. You can find like 10, 20 videos I made on last 10-day revision. You can read that. You should not, main notes are not revisable, Ekta. You cannot revise main notes. That's the entire point. When you're making notes till June, you have to not make, that's why I'm saying pre-made main notes are not revisable. You have to make notes. If you're not able to revise main notes right now, I would advise you go to revision notes and revise them. There will be more than sufficient. Content-wise, they are more than sufficient. The revision notes are content-wise more than sufficient. If you have understood the concept, then shift to revision notes right now. Just revise the revision notes. They will be more than enough. Haven't studied pharma. What should I do to cover it? Like I said, if you have not done one particular subject, past 3 to 5 year papers, just do that. That's more than enough for the current time being. If you have just one month for the exam to go. How to remember milestones, I told you, right? You cannot remember milestones. You have to revise them again and again. Please revise them one day before the exams. Okay. How to keep a hold of nerves during exams if difficult questions keep on coming again and again. यार इसका ना एक सिंपल मैं फंडा बताता हूँ. You have 300 questions. You can afford to get 150 questions incorrect. 50% questions you can get incorrect and still pass. 3 क्वेश्चन नहीं आते, कोई फर्क नहीं पड़ता. 5 क्वेश्चन नहीं आते, कोई फर्क नहीं पड़ता. 15 नहीं आते, कोई फर्क नहीं पड़ता. 16 से स्टार्ट कर दे यार. Let go of whatever questions you don't know. You don't know. मैं कह रहा हूँ 15 के 15 क्वेश्चन में सारे ऑप्शन ए मार दे. सारे ए मार दे. तब भी 4 तो सही हो जाएंगे. प्रोबेबिलिटी के हिसाब से 4 तो तब भी सही हो जाएंगे. 16 में से जब से आना शुरू हो जाए, शुरू कर दे. किस बात की टेंशन है, राइट? इतना वो नहीं करना, इतना परेशानी होना एग्जाम को लेके. डोंट बी टू स्कैर्ड ऑफ द एग्जाम. Right, I think I've answered most of the questions, Q&A questions. All right. With this, I think I'll take leave.